name is Dr.Salah Abderaof. I would like to present this interesting case which we had a couple of months ago. Patient presented with dense hemiplegia in the left side, aphasic. We did an urgent angiogram for her. We find out that the left cerebral circulation and posterior cerebral circulation were normal. And what you are seeing here is a total occlusion of the right internal carotid artery with tight stenosis at the site of bifurcation. I choose to go for reversed flow technique to trying to have an access to the right internal carotid artery. Here I did engaged within the right internal carotid artery. Then I did an angioplasty while keeping the reverse flow, and some debris and the thrombus were being extracted. I kept the blood flow draining into the outside the sheath. Here you can see there is still a lot of residue of a thrombus. But I give a small amount of contrast so as not to push them toward the brain. I did serial angioplasties, then I sucked thrombus. I kept on sucking the thrombus from now and then. Then I plan to insert and deploy a stent. I choose to go for conical shape stent, 9 mm at the common carotid, while 7 mm into the internal carotid. But it's important here to emphasize that the location of the distal balloon in the MUMA, it should be at the site of the origin of external carotid. This is very important to prevent the collateral to refill the internal carotid from the other side of the face. Here, after the deployment of internal carotid, there is still a residue of a thrombus. I could squeeze them because the flow is reversed. We can keep on sucking the thrombus. Now I managed to go inside the brain. There was a tiny thrombus. You could see the post-angio that we restored the good flow to the right side of the brain. Patient did show improvement on the table. She started moving her left limb. Thank you very much.
For stroke management, I think we have a few comments about that. First of all, you have to do it in a very organized program because it is really effective. It's the same way with primary PCI for acute myocardial infarction. And you should have really an established program so you don't waste time. You have a programmed investigation because these patients should have a CT scan before your intervention. And then regarding the data, yes, there was 2 articles in New England Journal of Medicine a few weeks ago considering that thrombectomy or retrieval of the thrombus is life-saving as well as stroke-modifying technique. It has been subjected to extensive investigation, and I think it is very helpful. I think this is what we are missing. The task is who's going to do it. And I was involved in one of these sessions in the EuroPCR 2 years ago about stroke management, acute stroke management. And we felt maybe we should have a collaborative team of stroke management, including the radiologists, interventional radiologists, as well as the cardiologists, because the numbers of the cardiologists are more available to do primary procedures, but they need to understand the anatomy and the physiology of the brain rather than just the stenting technique, because a lot of these patients, they don't need stents. They need retrieval of the thrombus. And there's a lot of comparison at the time window of opportunity for your interference is different from intravenous thrombolytic therapy to intracranial thrombolytic therapy to retrieval thrombectomy. And I think maybe this is worth a full session in the future, Mahmoud, to discuss acute stroke management from interventional and therapeutic point of view. But I think this is what I would like to end on this, and if you have any comments about that.
Yes, definitely. The thing that this kind of therapy is missing in our part of the world. And I wish that we still can
offer a lot for the patient, which is not being given so far. I wish in the near future that the awareness of the hospital to deal with these emergencies should change the classical thinking which was in the past, putting them in antiplatelets or just wait for the ICU. There is a work can be done which is not being done. So I wish with your cooperation that we can teach the people, teach the staff to recognize such things. It can be.
I think team effort is the key issue here of all people involved, including the emergency room. Thank you very much. We move to the next Ayman.